you know how challenging it can be when you're faced with a squirming toddler who needs a thorough eye exam? Fear not. Anna McDonald, who you may remember from the EM Cases Course live podcast last year on ocular trauma, gives us her time-saving and frustration-saving tricks and tips on the pediatric eye exam.
You're coming to the end of your shift, and you pick up the chart of your last patient, 2-year-old Lucy. This evening, her 5-year-old big sister was trying out her new karate moves and accidentally hit Lucy in the eye. From the door of the room, you can see she isn't a happy camper. Mom is trying to get her to sit still in the eye examination chair, but Lucy isn't having it. Examining this kid's eyes is not going to be easy. You take a deep breath, muster all of your energy, and enter the room. Kids are often stronger and more stubborn than they look. We all have tricks for looking into toddlers' ears and throats, often involving some form of restraint from the parent and then a bit of strong-arming on your part. But what about the eye exam? You can't just hold kids down and crank open their eyelids. You need some level of cooperation from them in order to really examine their eyes. How do you test a baby's visual acuity? What about a toddler's visual fields? How can you check eye alignment when the kid just won't sit still? As with anything in kids, when examining their eyes, you need to keep them happy and trick them into doing what you want them to do. I start just by watching them from a distance. This general observation already can tell you a lot about a child's eyes. Is their eye red? Is there any swelling? Do they look comfortable? Is there any discharge or excessive tearing? Now, if their eye's so painful they can't even open it long enough for you to see what's going on, they may need some tetracaine eye drops. But as you know, getting eye drops into a kid's eyes can be nearly impossible. They scream, they scrunch up their eyes as hard as they can, and they won't sit still. So the trick here is to use the child's own eyes to distribute the drops. With a parent holding the child, preferably either lying across their lap or with their head back to take advantage of gravity, make a little puddle of tetracaine in the inner corner of their eye. The moment they open their eyes, even a little bit, the medication will be distributed across the eye. Warn the parents that the child will be a bit unhappy for a short while because the drops do sting initially, but then the freezing will kick in and they'll be much more comfortable. After I've deposited the drops, I usually wander off for a bit, just to let kiddos settle with their parents. Now you have their eyes open, you can get a sense of their visual acuity. It's pretty easy if they can read letters or identify shapes on a pediatric Snellen chart, but it's a bit more difficult with preverbal children. With smaller children, they should be able to fix and follow. You can use a toy to get their attention and see if their eyes will follow it. If they can't fix and follow, see at least if they blink to light. This is a bit like the light perception only designation we use for adults. But remember, the attention span of a toddler is shorter even than the attention span of an emerge doc, so one toy might not hold their attention for long. This is where you bring out your secret weapon, the best tool we have for examining kids. You all know what I'm talking about. It's the smartphone. Best to use one belonging to the parents if possible, because the moment the kids get their hands on that phone, it is going in their mouth. But I will use my own phone if absolutely necessary. Go to YouTube, put on some Peppa Pig or Paw Patrol or possibly Baby Shark, anything that will catch their attention and keep it. And then use the phone to see if they fix and follow, and bring it up close to their face to check accommodation. You can also check their extraocular movements at the same time. When you have the child's attention fixed on a toy or a smartphone, use this time to check the pupillary responses, the eye alignment, and the visual fields. Pupillary testing is pretty straightforward, but alignment can be a bit trickier. When they're fixated on the toy or screen, cover and uncover each eye with your hand. Carefully watch the eye as you uncover it to see if it moves back to bring it back into alignment. I know we usually talk about this test in the context of benign childhood strabismus, but in the right clinical context, abnormal alignment may point towards more emergent issues like cranial nerve palsies or limitation of extraocular movements, for example, in orbital cellulitis. Subtle difference in alignment of the eyes can be difficult to detect, so use the reflection of the light on the cornea to guide you just as you would in an adult. Then you want to check visual fields. The key here is to keep them focused on something central, like the parent's phone, and then bring in another toy from the side. If you don't have another toy, a blown-up glove can do the trick. Just make sure the toy doesn't rattle or make a noise, because they'll be drawn by the sound instead of their peripheral vision. And now we start getting into the really tricky stuff, looking at the eye structures. Of course, if the child's old enough to cooperate with a slit lamp exam, your life is much easier. But if not, think about using the ophthalmoscope, as it's a bit less intimidating for kids. Again, it helps to keep the child focused on something like a toy or a screen, and then you can come in from the side to look at their eye. There's 3 main things the ophthalmoscope is useful for in the peds eye exam. The first is red reflex. An intact red reflex tells you there's nothing blocking your vision of the retina, like corneal opacities or cataracts or intraocular masses. Second, you can use it like a mini slit lamp to look at the anterior structures of the eye. You usually can get a good enough view to assess for corneal ulcers or pupillary abnormalities. I also use the cobalt blue setting on the ophthalmoscope to look for fluorescein uptake if I'm looking for corneal abrasions. Third, you certainly can try to get a view of the disc. Although if you have trouble with this in adults, kids are going to be almost impossible. The faster you can get a view, the better, so practice makes perfect. For the vast majority of pediatric eye complaints you see in the ED, these physical exam tricks will be good enough. But sometimes you need a closer look at the eye, or the child just won't cooperate despite your best efforts. Think about using your ultrasound. You can use this in the same way you would for an adult, to look at all the eye structures and possibly to measure the optic nerve sheath diameter if that's relevant. You can also use an eye ultrasound to look at eye function, specifically pupillary response and extraocular movements. If all else fails and you're still really concerned, you may need to use sedation to get a thorough eye exam.
All right, quick review of the quick hit on pediatric eye exam tips and tricks. The key is to get and keep the child's attention. Start off by simply observing them from the corner of the room. If they don't open their eyes because of pain, use the tetracaine eye drop trick. That little puddle of drops in the inner corner of the eye. I use that one all the time. It's great. Visual acuity for pre-verbal kids? Well, start with seeing if they can fix and follow to your smartphone, and if they can't, see if they can blink to light. And while you're at it with the phone, check pupillary responses, and with the second toy, visual fields. You can even use the phone for visual alignment along with the cover-uncover test. That's it for the phone. Then there's the ophthalmoscope, and it's useful for 3 things. The red reflex as a substitute for the slit lamp, and to look at the fundus if you're quick enough. If none of this works, grab your ultrasound, a Tegaderm patch over the eye, and some gel, and if that doesn't fly, you might need to sedate the child.